individual symptoms. What's the most bothersome to them, what their individual risk factors are. For example, family history, you mentioned, of breast cancer, also family history of things like osteoporosis, cardiovascular disease, diabetes. So kind of getting a sense of what that woman's individual health risks are, what their desires are. So I even encourage my patients to kind of think philosophically about it. Do you think this is normal? Are we really, perhaps supposed to live till 90 with no hormones? How do you feel about it? Because I really try to partner with the patient and say, like, you're the expert in kind of how you feel. Sometimes in someone like you, Tamsen, getting that information might be a huge relief, just understanding this is what it is. For other people, might immediately say, I want to treat as much of this as I can. How can I really improve these symptoms? And we can get into treatment. But I kind of look at what their individual desires are, their goals, their health risks. And do we have to get perhaps like a bone density to look at their bone where they start off from? But I'd love to hear what Mary Jane approaches that too.
Absolutely. And there's one other thing that I think that we need to throw into the initial evaluation is, have you completed your childbearing, or are you thinking about having another kid, particularly or having a kid, particularly if you're dealing with a woman in her 30s or early 40s. Many people are delaying childbearing, and we have to say, okay, where are we as far as, what are your thoughts and hopes as far as childbearing? And we have to throw that in too, because a lot of the therapies that we use for perimenopause, I find the most common therapy that I use for perimenopausal issues is if somebody who's really not nowhere near the last menstrual period. I use a lot of low dose birth control pills for these folks. If they're a candidate. Obviously someone's sitting there smoking their cigarettes, she ain't getting birth control pills from me. But if somebody's, one of these folks who goes to the gym 12 hours a day and eats nothing but sprouts, she's certainly a good candidate for birth control pills, presuming she's not a smoker. And that can be really helpful, because what birth control pills do is they shut your ovaries down. And I try to do this in my best robot voice when I tell people, what am I doing? I am giving you a fixed level of estrogen. So I'm going to try to take over, shut your ovaries from doing this up and down roller coaster, give you a fixed level, give you some progestin, a synthetic progesterone, so that we regulate the bleeding for you, so you're not going to get these fiesta bleeds, and make you more comfortable. So that's something. But if she wants to have a kid, I'm not going to give her birth control pills.
Right. Let me ask you this. When we're talking about addressing hot flashes, hormone therapy, and also some new treatments that are out there as well, which is very encouraging to see, are those options if somebody's walking into you with these symptoms?
Absolutely, all of the above. And that's why, if you want, there are ways we can kind of look at individual symptoms in kind of a piecemeal way, right? For just the hot flashes, or just the mood symptoms, just the sleep, or there can be kind of more holistic approaches if someone really understands that it's the hormonal changes and they're interested. We know the single best treatment for hot flashes and sleep issues is hormone therapy, but fortunately there are a lot of other options for people that either choose not to or aren't candidates for. Particularly this new one, fezolinetant, that actually acts centrally at the brain with a thermoregulatory center, but that's going to really only address hot flashes from what we understand it. It's not going to impact what Mary Jane mentioned, is like dry skin, hair changes, perhaps metabolic changes. So it depends if you want to, approach it one thing at a time. That's how I explain it. Mary Jane, you as well?
Yeah, absolutely. And the one other thing, given your concern, Tamsen, as far as your mom's history, that indeed one thing that we can say right off the bat to patients is that family history does not preclude hormonal therapy. Personal history of breast cancer, most folks would not recommend doing any hormone therapy. But as far as familial incidents, increasing that risk, yes, basically, and this we actually have from the WHI, which most people don't realize. It's right in the WHI that having a family history, yes, in and of itself, it has an impact on breast cancer risk. But taking estrogen therapy is not, and the analogy I always say, it is not putting gasoline on the fire. And most women are convinced it's gasoline on the fire.
And I'd love
to have a few.
And I just
go ahead. Of course.
Totally appropriate right here. Those women who happen to have had a hysterectomy, which are probably about 1 in 5 US women, it's approximately, national numbers about 20%. There's a lot of misinformation that actually giving estrogen to that population actually decreases the risk of breast cancer. And nobody hears this. It decreases the risk of breast cancer about 23%. And it actually decreases the risk of osteoporosis, colon cancer, cardiovascular disease, all-cause mortality, particularly if that woman has gone through menopause early. So I think many women don't get that messaging. They're afraid of breast cancer, and they don't actually realize that estrogen alone actually decreases that risk of breast cancer. So I hope people hear that.
And the one other thing going into the hysterectomy business is Robin, mentioned that indeed a lot of women have had hysterectomies, that indeed having a hysterectomy in and of itself actually tends to, even if your ovaries are left in place, it tends to accelerate the age at menopause by probably 1 to 2 years, because of probably changes in blood flow in the pelvis, things like that.
Sure.
So that, if you're saying, oh, gee, I had a hysterectomy, well, my menopause, no, your menopause may be earlier. So you may be even younger than the average woman going through it.
So I want to add, I want to just pop some questions in here just as we go before we have right before we do the next case study. Jen is asking, can you speak to surgical menopause and resources for it? And I think we addressed breast cancer a bit, which could be, one of the reasons, a surgical menopause, but can you speak to that, just some resources for that?
As far as what resources women can use, as far as
where can women go to find out a little bit more about that? Because surgical menopause is one of those things that is not left out of the conversation, but is another whole area, another way that things need to be addressed.
Absolutely. I mean, a couple of resources, the North American Menopause Society, as I still call it, which is really officially now the Menopause Society, but the website hasn't changed. It's menopause.org. And on the website, there are the guidelines, the Menopause Society guidelines for hormone therapy, which came out in 2022. The non-hormonal guidelines came out this year, 23. They're there, they're posted. Anybody can read them. You can also go to my exciting website, madameovary.com, and take a look and learn about this sort of thing. So those things are quite important there. The one other thing, though, that I would counsel anybody who's listening, if you have gone through surgical menopause, your ovaries are gone, and you're young. Now, not that 51 isn't young. That's very young. It's extremely young to me. But somebody who's gone through menopause at 35 or 40, something like that, is a real youngster. And we do know, and we have very good data on this, that basically if you don't give these women estrogen, okay, and presumably they are, I mean, if they've had a personal history of breast cancer, well, that's a different story. Basically, just about everybody else can take estrogen therapy. And again, an estrogen alone, if she's had her uterus out, no problem. That's easy. So, and we do know that those women are at significant increased risk for osteoporosis, as Robin's been mentioning, for heart disease. And the other thing, and again, unfortunately, most American women don't really care about their hearts. So that's a whole nother story. That they care about cancer, but they don't care about their hearts, but they should. But anyway, the other thing, though, that American women do care about, and this is an important thing, is dementia. And we have some very nice data from the Mayo Clinic, which is a reputable outfit, showing, and studies done by the folks there, the neurologists there, Dr. Rocca, that shows that if you have your ovaries taken out before the age of 45, and you don't take estrogen therapy, you have about a 3-fold increased risk of being diagnosed with dementia. And that can be stopped by taking estrogen. Now, the issue of using estrogen in somebody who goes through menopause at age 51 or 52, a little more controversial, but very good to be safe. If you're under 45, definitely you want to talk to somebody about being on some estrogen.
All right, let's go to case study number 2. Early post-menopause, 1 year. And we're talking about a woman in this stage of life. And Dr. Noble, let me start with you. What does it mean at this point to be in menopause? And I guess, we've learned there's like kind of these 3 categories. Is there such a thing as post-menopausal?
Yes. I mean, I find a lot of the terminology a little bit confusing, and it just adds to the confusion of the whole time. So I generally, divide it into perimenopause is where we see all this chaotic, hormonal, peaks and troughs and very regular bleeding. That menopause definition, as Mary Jane mentioned, is a retrospective diagnosis when you've gone a whole year, right? So then when you've gone a whole year, you're much less likely to have one more kind of ovulatory event. But what's interesting, and I think this has been under-recognized, those ovaries are still functioning, and we still sometimes have some hormonal kind of peaks and troughs, sometimes some intermittent breast tenderness, bloating. And to get back to that surgical menopause question, often that's a more challenging transition because it's so abrupt. So in natural menopause, they still have some hormonal production. And in that first year, they might still, many women have hot flashes for years and years, if not decades. So they start to experience more of the hot flashes, sometimes sleep changes, as Mary Jane mentioned, vaginal dryness, sometimes urinary frequency, pain with sex. But what can be confusing is some women have almost no symptoms at all. They can be blissfully aware. And that's an important thing to be mindful too, because it accelerates our cardiovascular disease risks, osteoporosis. We lose as much as 3 to 5% of our bone density in each year around menopause. And we have an increased risk of diabetes, to weight gain. So I think being aware of all these changes, even if people don't really have symptoms, is critically important. It's almost that time to double down on healthy lifestyle choices, understanding what our individual risks are, and understanding what our goals are. That's helpful.
And I find that menopause is a time that I think we can make some differences in women's lives. The two times that I think that are there is pregnancy and menopause, where we can say, hey, let's think about where you are. I mean, if somebody's been smoking cigarettes and she's pregnant, we can say, come on, now you really have to stop. And sometimes that'll motivate people to do it, whereas it's tough to do it before then. And I think with the menopause transition, I think a lot of women will say, yeah, I got to do something. I got to go to the gym. I got to stop smoking cigarettes. I got to, stop drinking too much. Well, they can make some really substantial changes. And I think that women are more motivated at that point.
But to get back to your question, I realized I didn't really answer it. Sometimes people say, am I through menopause? Am I through it? And I often tell them, you're not through it, you're in it. It's kind of this new stage when your hormone levels are really low. And I think that's confusing for people. There's that menopausal transition. And then once you're in it, we sometimes call it the post-menopause, but it's really they're menopausal for the duration of their lives, whether we choose to treat that or not, if that helps.
I hear often like, oh, that was a long time ago for me. And I was like, no, it's now.
That's why we all get wrong. Yes, no, it's not. Now, there is one other hormone that we should bring in just to complicate things just a little bit.
Let's do it. Let's do it.
Why not? Why not? We have to talk a little bit about testosterone, because ovaries, a lot of my patients say testosterone, that's the guy's hormone. I say there are very few that are sex specific. Guys make estrogen. You may not want to tell them that, but they do. They make actually more estrogen than we do when they're quote unquote in the postmenopausal time frame. But the ovaries actually have a longer course of making testosterone. So even if the ovaries are pretty much pooping out at 50, 51, 2, as far as estrogen production, they produce a moderate amount of testosterone for about another 10 years. Okay. Part of the reason that when we do hysterectomies these days on women, for whatever reason, when I was a little kid learning how to do hysterectomies, that if somebody were 50 years old and having a hysterectomy for whatever reason, you take out her ovaries. That was, that kind of idiot are you if you don't take out her ovaries. But the key thing is now the official recommendation is no, you don't take out her ovaries, presuming she's not a high risk candidate for ovarian cancer or something like that, because they're sitting there making some estrogen, as Robin pointed out, and they're making some testosterone also. And the testosterone has some value as well. So we don't necessarily push people to have ovaries out, at the age of 50.
Well, so let me ask you this question. Dr. Minkin, I'll start with you. Can a woman still have symptoms a year after menopause, obviously? And how different are they from the perimenopause time?
Well, that's a good question. And the answer is all over the place. And that basically that women can have hot flashes forever. And again, the other thing that's really interesting to me about menopause is how different groups of people experience things differently. Different countries have certain, like hot flashes are the most predominant symptom in the US. If we're giving this talk in the Philippines, the most symptomatic problem is achiness. Do we know why? No, I mean, and I keep telling my medical students, there's a Nobel Prize in that. Your mother would really like you to win one. So the key thing is that we got to do some research. So that's very important. And so these kind of symptoms occur. And the other thing is in the United States itself, there's a very nice study that's still going on, just got some more funding, called the Study of Women's Health Across the Nation, which is the SWAN study. And what they've discovered is that basically the average duration may be 7.4 years of hot flashes. Hurrah. But basically women, African-American women, seem to have the highest burden of hot flashes, which go on for an average of 10 years. Whereas for women of Asian backgrounds, they may have hot flashes less for 5 years, whereas the average overall is about 7.4.
Well, so let me ask you, if you have a woman that is highly symptomatic, have you had a patient that's highly symptomatic 1 year after a menopause, and what do you do there? Do you adjust something? I mean, is that where you're adjusting estrogen if they decide that they're going to do hormone therapy?
Oh, we certainly play with it. Robin plays with it a lot. Absolutely.
I think it can be confusing because sometimes their symptoms can actually worsen. And we think, as those ovaries are producing less hormone, they might actually have worse and hot flashes. I think it goes back to what kind of management they want. For example, if they're using SSRIs, or SNRIs, which are the, selective serotonin reuptake inhibitors, often used as antidepressants for other reasons, they can be somewhat helpful. So perhaps that was getting them through before, and then it's no longer working as well for them, or maybe they're now having vaginal dryness and discomfort, and they're thinking, that's what I wanted to do before, but maybe now I want to look at, kind of doing maybe something more global, like a systemic hormone therapy, or maybe pair that with a local vaginal estrogen if that's kind of cropped up, like if they have more urinary frequency and urgency and pain with sex, whereas they didn't in that first year, then you want to kind of adjust and do that. So I think, none of these things are really finite, and I think we should, welcome kind of those changes and adapt to the needs.
What about supplements? Because I get that question a lot, and I know I know a lot of people have a lot of different answers for it. What supplements though might work during this time when we're talking about early postmenopause, about a year in?
Mary Jane, you want to start and I'll follow up?
If we're supposedly espousing the Menopause Society's official statement, and Rob and I are both active members of the society, no question about it, but they say no herbal supplements work. Have a nice day. I don't think that's the case. I do recommend certain supplements, and unfortunately, and I may get some people angry with me, but I'm used to pissing people off, so this is no problem. But basically, we do not regulate our supplements in the United States very well.
Right.
So then unfortunately, my patients is I could go dig up some dirt right outside of my office here, come in and say, here's some black cohosh, have a nice day. And nobody would stop me. And that's not right. Whereas in countries like Germany and Sweden, they'll throw you in jail if you go around screwing around like that. And if you look at Germany, they actually have a PDR for herbal products. And you have to qualify to get into this, physician's desk reference. And so you have to meet certain standards. So in general, I tend to go with European products in general.
Right.
Excuse me. One product I do like a lot is a German black cohosh product called the Remifem, which has been around for 60 years and is standardized and stuff like that. So as I say to patients, I may not know that black cohosh is going to help you, but at least I know what you're getting in this product is black cohosh. Instead, there have been studies done in the US,
Right.
which might not be. Another product that I think that's out there that folks, many of my patients use with good success, something called Relazin, which is a Swedish pollen extract. And again, Sweden regulates things, so I know what they're getting. And again, they are fine. They can be safely used with people with breast cancer. It's not a problem. These are non-estrogenic substances. We actually know the mechanism of action in a couple of these products. So those are products that, I have used. Now, and of course, the other thing that some products probably don't, and the other thing, if you talk about placebo effects for hot flashes, any study that is done on a product for hot flashes has to have a placebo arm. Okay. Because if you have a product that comes and say, my God, I'm getting 35% of my patients with this product are getting better. Well, if you look at any study of a hot flash remedy and has a placebo arm, this placebo is in general about 35%.
Okay.
So it's got to be superior to that to say, yes, this product really works. So, and
Okay.
I think the thing that you have to take into account, I think, is I sound fancy because I don't want to sound like a person from New Jersey here. I can say some things in Latin, and you say primum non nocere secundum beneficere. And what does that mean? It means first do no harm, second do good. So, if one of my patients comes in and says, Mary Jane, I found this super thing for hot flashes and it's called arsenic, I'm probably not going to encourage her to continue with it. But if she comes in and says, Mary Jane,
Arsenic's a poison, just in case.
Arsenic is a poison, guys. Yeah, do not take it. Do not take it.
Thank you for the clarification.
Very excellent, Robin. Thank you. She's been doing this for a long time. That's excellent. So anyway, so the key thing is, but if somebody comes in and says, evening primrose oil is really helping my hot flashes,
Yeah.
I'd say, God bless you. That's great.
Yeah. Yeah.
So
no,
I would, similarly, I would say, I would give the data that we have, and certainly I've learned from Mary Jane, these European products seem to be better regulated for sure. What we don't do well enough in kind of Western medicine is kind of empower the person to do what feels right for them. So I think if someone's doing something that they really enjoy doing, they think it's helpful, there is a powerful placebo effect, then they should be empowered to kind of do what they want. So it's not harmful. But I do think that, we have to be mindful that a lot of people are spending an awful lot of money. There's a lot of profiteering. So I generally say, look, the evidence isn't great. You should probably save your money. And if you're really suffering from these symptoms, there are other things that we know seem to work better. So I'm really mindful that I don't want people spending a lot of money on stuff that might not be regulated.
No, it's a good point. All right. So I want to hit one more point on this case study, and then we'll move on to number 3. The patient with minimal symptoms. Dr. Noble, what do you recommend for a patient with minimal symptoms? Do you essentially send them home? Do you say, listen, you should get on hormone therapy because of future issues, bone health, heart? What is the suggestion for that?
With minimal symptoms, my goal is that they get educated, that they understand, even if they're not really symptomatic, that this is a time where really their cardiovascular disease risk really changes, their osteoporosis risk changes. So many, systems, body systems really change. So even if they're not symptomatic, I want them to be aware that not only are these things changing, but this is an opportunity to potentially be proactive for, say, something like osteoporosis. And the exception, if they've had a hysterectomy, the data seems overwhelmingly to suggest that a hysterectomized person should be on estrogen for those reasons that we mentioned before. So I want them empowered to kind of understand that things are changing, that they have an option. Because one thing we haven't gotten into, I think it's in our last case study, is that there is a timing hypothesis that the sooner we start something, the safer and the better for the person. So I don't want them in 10 years have this hindsight's 2020 and thinking, gosh, I coulda, shoulda, woulda done that 10 years ago. My patients, I want them to kind of understand the changes and kind of make a decision with the best information that we have, so they don't feel like they didn't get that opportunity later. That's how I approach.
Okay. And Dr. Minkin, we do have a question that came in, and I want to ask you. Did you have one more thing you wanted to add to this? I wanted to ask you this question.
One more thing that I wanted to ask to address something Robin had stated earlier about doing a bone density on people. And officially, actually, it is not recommended unless somebody is high risk to get a bone density.
Okay.
However, you can look at risk factors in just about everybody. And so I tend to like to get a bone density as a baseline. Even if I'm not going to push them towards hormone therapy, I find doing a bone density is a very powerful tool to get people to get some exercise, do some strength training, to get their vitamin D on board, all the good things they should be doing. And I say, look at your bones. You don't want something terrible to happen. But in that, Robin's also bringing up an important point, is that the timing hypothesis comes into play on bones as well, because Robin had already talked about the bone loss that happens, and the most precipitous time of bone loss is your first 4 years after menopause. So that's the biggest bone loss. So if you find somebody with a bone density within a year or two after their last period, and she's got problems there, you want to get her kicked on some, ideally if she can take estrogen, some estrogen, to try to prevent further bone loss. And the other thing that's really interesting about bone is that the amount of estrogen that you need to give somebody is tiny. You really can use a very small amount of estrogen and be very effective as far as preventing bone loss.
Okay. All right. So let me keep you here on this one. A question came in. I'm in surgical menopause. I'm almost 51. I'm on the estrogen patch. I have no ovaries. What is your opinion on taking progesterone? My gynecologist said it's not harmful, but it's not necessary. My regular doctor said I should take it. What's your opinion on this?
I know Robin's got some strong opinions on this, which I echo, but you go first.
That's actually, my understanding is there isn't any data that supports that it would be helpful, although we know progesterone can actually be a little bit helpful for bone density. But the concern is that estrogen plus progesterone is what we feel increases that risk of breast cancer at 5 to 7 years. So I would tell that person that I don't know of any real reason you should be on it, number one. And number two, I'm concerned that you might be increasing your risk of breast cancer, whereas estrogen alone won't increase. The question I was going to have was, what about testosterone? Because as Mary mentioned, that surgical menopause patient really has lost not only her estrogen, but a good percentage of her testosterone production. We know testosterone has impact on bone density as well. So I'll leave that. I'll punt that to Mary Jane if she wants to take the testosterone piece. And I'd love to hear what she says about the progesterone as well.
Yeah, I'm certainly happy. And also if she's got an issue with libido, and that's we do have very nice data that libido in postmenopausal women seems to be helped by giving testosterone. And if she's got a loss of libido, I have very low thresholds about telling her to take some testosterone. People I don't like to give testosterone are soprano opera singers. Other than that, no problem giving it to them. But anyway, but basically the progesterone question, there's one group of people that I have to confess my sins, that I would give progesterone after a hysterectomy. If somebody's got some real sleep issues, natural progesterone, micronized natural progesterone does seem to act well for sleep. It makes a lot of people sleepy, better sleep. And so for those folks, I might. And the other thing about micronized natural progesterone, if you look at European data, there are no prospective randomized trials. This is observational data from Europe that shows that the combination of estrogen plus micronized natural progesterone does not seem to increase your risk of breast cancer. So that if somebody wants to use progesterone, I wouldn't use a synthetic. I would use micronized natural progesterone. And again, I would only use it if they really had sleep issues and they really found that micronized natural progesterone really was a great sleeper.
Okay. All right. So let's do case study number 3. 8 years post-menopause, never received treatment. And I feel like that might be from a lot of the women that I hear, like, that was a long time in the past. I breezed right through it. So never received treatments. Now we'll see what there's, some different parts of this. So let's address a few things. A sexually active woman who has painful sex and no desire. You mentioned testosterone, so I think that moves us right into this. What is your preferred approach for a sexually active woman who has painful sex?
So I'll start there, and then I can have Mary Jane talk about testosterone too. So we know
great.
Vaginal estrogen. So we mentioned the timing hypothesis. Again, 8 years doesn't say that she's absolutely not a candidate for systemic hormone, but it tends to be less favorable. So if they're distant from menopause, local vaginal estrogens are not only really useful and helpful for pain with sex, but they're incredibly important and underutilized nationally because they statistically decrease the risk of urinary tract infection by about 50%. And that is a cause of a lot of hospitalizations, a huge number of healthcare dollars and morbidity. So urinary tract infections, urinary urgency, pain with sex, vaginal dryness, and even a little bit helpful for things like prolapse issues. And when gravity kind of the pelvic organs prolapse a little bit. So local vaginal estrogens tremendously important in that person and will really improve sexual function, pain with sex, arousal, the blood flow to the clitoral hood and the vulva and the vagina. And then I'll kind of Mary Jane the testosterone thing.
Okay. Well, and a couple of other things about the vaginal estrogen. One thing that I do want to mention, and Robin has spent many hours of her life doing this. She just didn't want to talk about it, counseling people to ignore the package insert that comes with the vaginal estrogen. That you will see, and so I want to tell everybody who's watching this, that indeed coming with the package of vaginal estrogen, cream, suppositories, whatever, is a statement saying that it lists all the potential symptoms of systemic estrogen. And we know that the amount of estrogen that's absorbed from the vaginal estrogen is so minuscule, it's a tiny amount, that if you use the proper doses and stuff like that, that the North American Menopause Society or the Menopause Society and the American College of OBGYNs have both issued official position statements saying that women who have breast cancer may use vaginal estrogens. That's how it gets absorbed. So when I tell that to patients that really, there's a statement we have for the women who have breast cancer, you don't got breast cancer, there's no reason you can't use vaginal estrogen. And the problem is that I spend at least a minute or two with anybody I write that prescription explaining that. And then the problem is they go home, their partner picks up the package insert and says, oh, it's not worth us having sex for you to die. Cancer. Right. So we're trying to get that out of the package insert. So anyway, so vaginal estrogen really just about everybody can use. And there are some over-the-counter non-hormonal things that are quite effective. Also some hyaluronic acid products, some, polyglycol. So there's plenty of stuff that's out there. As far as the testosterone, the problem with the testosterone is unfortunately accessibility, because although the Menopause Society, the International Menopause Society, everybody has official position statement based on data that shows that testosterone helps for libido, our FDA has not approved a testosterone for women. And so what we have to do is we have to either use, and there are about 10 different varieties for guys that are FDA approved. So what our patients can do is use a little teensy bit of the guy stuff, Unfortunately, that's hard to regulate because it's a little tiny amount. And the other thing, though, you can get it from a compounding pharmacy. And although none of us are big on using compounding pharmacies for products you can get from the FDA, an FDA approved product, since there's no FDA approved product, I just, have gotten myself familiar with the different compounding pharmacies in the area and, use the pharmacies that I know can come up with a pretty good product for my patients, which we do get.
Okay, so I want to ask one more question on this, and I know we have a bunch of questions that have come in, and I want to get to those before we come up to the end. Just real quick, and Dr. Noble, I'll ask you this: is it too late to go on hormone therapy if you have, if we're in case study number 3, 8 years post-menopausal but never received treatment?
No, it's not too late. I mean, the guidelines are within 10 years and under the age of 60. But what I like to explain to people is, the understanding of the timing hypothesis is that we probably developed some cardiovascular plaques and some cardiovascular disease in that ensuing time. And then perhaps that estradiol there's a little bit more elasticity in those blood vessels. So we think there's an increased risk of heart attack and stroke, especially in the first 6 to 12 months. So if I have that person that's 8 or even 10 years and, perhaps they have an unbelievable healthy diet, their lipid profile looks beautiful, their cardiovascular risk factors are really low, you can calculate their CVD risk, for example. If it's really low and they understand, I'm a big believer in shared decision-making, informed consent. And if they are facing either this or an osteoporosis medication and they say, I really want to do this, and I'm 8, 9 years out, I admit that I've even had somebody who was, say, 62 in a similar situation, that with informed consent, I don't believe in black and white lines. I try not to.
And
I know. Okay, go ahead.
Oh, I would agree completely. And the one other thing that I might do in that situation, because there are oral estrogens and there are transdermal estrogens. And given the fact that as we get older, our risk of getting thrombophlebitis goes up, unfortunately, that I would tend to say, why don't we use a transdermal estrogen as opposed to an oral estrogen if somebody's a bit older, to try to minimize that risk.
And I would go one step further and say I'd only probably offer, that 6162. I really prefer to use the transdermal because we think the safety data is better. And those are gels, patches, even the vaginal ring is a great option, but something that doesn't seem to increase our risk of clot and stroke as much. And we think is probably safer.
Yeah.
Okay. So I'll have you maybe each one of you answer one of these at a time, just so we can get through as many as possible. So in either one of you can decide which one takes which question. Is an IUD effective in addressing some of the perimenopausal symptoms?
Yeah, absolutely. The bleeding, incredibly helpful in the bleeding. And it's a great adjunct to protect the endometrial lining for hormone therapy. I think the levonorgestrel IUD, obviously not the copper IUD, I'm referring to the progesterone containing one, is a great option. I don't find, because it's got such a low level of systemic progesterone, it's probably not all that helpful in the hormonal symptoms, incredibly helpful in the bleeding symptoms and protecting the endometrial lining.
And preventing pregnancy.
Exactly.
Oh, yes. And that. Okay. Can you tell us more about the frozen shoulder? I have a shoulder impingement that just came on out of the blue. Could it be due to menopause? I'm 58 and have a 50 milligram estradiol patches, only 3 years, and have had a hysterectomy in my 40s, but still have my ovaries.
The answer is you might want to play with your estrogens a little bit. In general, I tend to find the people with the arthritic symptoms are not on any estrogens when I see them, and I say, well, maybe you want to try a little bit of estrogen and see what happens. And again, as a menopause doc, as we are, we deal a lot with arthritic conditions, and there's where I sometimes will use some non-medical herbal type options and things like that. I'm a big glucosamine fan, for example. I think there's enough supported glucosamine chondroitin, and some people are into turmeric, and there are some topical anti-inflammatories that can be helpful for certain kinds of, particularly knees and fingers. So, but you can play with the estrogen a little bit. There's no harm in just bumping it up to saying for a 0.075 patch and see what happens, see if you feel better with it.
In general, I might say, though, because it's remote from that menopausal transition, she's been on hormone replacement, and now she develops a frozen shoulder, I'd be looking at other causes as the more prominent ones.
Yeah.
Okay. I had a hysterectomy last year, everything removed except ovaries 3 months ago. Gyno started me on NP thyroid for low end of normal thyroid level. I'm sorry, NP thyroid for low end of normal thyroid levels. About a week started having high blood pressure, heart palpitations, flushing. Primary doctor told me to stop the NP thyroid. Symptoms didn't go away, but worsened. Cardiologist did tests, said heart is fine. Had to be put on blood pressure medication. Could hormones have caused this? Oh, progesterone was added and then doubled based on the blood work.
You want to take
I
that?
don't, yeah,
Is that
I
one
don't
too
know
much?
why. I
Well,
know,
we want to do it offline?
I might not
Okay.
understand it because I don't know why the progesterone was added because apparently there was a hysterectomy done. So my read would be that estradiol would have been
Yeah.
the most important thing to start, presumably transdermal. We don't think it increases that risk of blood pressure. I think the
Okay.
thyroid one is a bit of a question. I'm not sure. Transdermal estrogen would have been my choice, and make sure it's an effective dose and then see what else settles out.
Okay.
Okay.
And that one's we have just in case you want to look at it offline. Do you have recommendations for fatigue?
Sure. I mean, the major thing with fatigue is, are you getting enough sleep?
And that.
I look at what's going on sleep-wise, because many women in perimenopause and menopause are not sleeping well, and it may be poor quality sleep. Even if they are sleeping, it may not be restful sleep. So again, using if she's not on hormone therapy, I would certainly suggest trying some hormone therapy. Again, very few people can't take it, and that's probably your best remedy for sleep. The other thing, I mean, there was a significant incidence of sleep apnea out there, so doing a sleep test, a sleep study, certainly a reasonable thing. Although estrogen, I probably would do estrogen even before I would do a sleep study to look at other causes. Also getting the partner out of the room who snores is also helpful. There's a lot of snoring out there that I hear about.
It jumps on the bed. I think a lot of people are more wakeful. As Mary Jane mentioned, there's a lot of sleep quality issues that sometimes aren't even appreciated. They just wake up and they haven't had good quality sleep. And then lastly, I'd say also there can be kind of overlying, sometimes mood and depression can contribute to fatigue. So you want to make sure that you're being adequately treated if there's a component of mood as well as sleep.
Yeah. And the other thing that the previous case mentioned was putting somebody on thyroid, but thyroid disease is more prevalent in women than it is in men. And among the guidelines from the American College of Physicians basically is periodically routinely checking thyroid levels in women.
Yeah.
So it's not a crazy idea to see what her thyroid function is doing as well.
Yeah. And I know there's a page on our Let's Talk Menopause.org talking about sleep. So I mean, it is a topic I never knew I needed to talk about so much. I was the girl that fell asleep anywhere and fell asleep in a moment. And then in a moment, it all changed. All right. I am perimenopausal. I've had several symptoms for about 5 years. My chief concerns are hot flashes, sleeping issues, and urinary issues, waking up 3 to 4 times a night to urinate. I'm taking local estrogen, vaginal, recently started progesterone. Thoughts?
Transdermal or systemic estrogen is where I would go. Mary Jane?
That's exactly where I would go. And again, and perimenopause, again, it's a little tricky to regulate the progesterone. Okay. And the other thing is she might be a candidate for birth control pills too. I mean, that's the other possibility. She's a good candidate. I mean, that certainly would help most likely. But as far as regulating the progesterone, what I sometimes will do is give people just estrogen, titrated for their symptoms as far as what they need. And we know their periods are going to get wacky at certain points or another. So what I usually will do is to say, okay, if you're getting your periods on your own, fine. But if you go more than 2 months or 3 months without a period, I certainly want to get you some progesterone to withdraw you and get rid of any lining that's building up. And this is also where a progestin IUD can be very helpful as well, because that'll prevent lining of the uterus. You can give estrogen as you wish.
Can I jump in real quick on the urinary symptoms? I think one thing that's underutilized sometimes is pelvic floor physical therapy, and oftentimes behavior modification, even education about kind of avoiding behaviors and getting up at night can really improve things for people. So it might be that there are some urinary issues, prolapse issues, urinary frequency that we should be addressing as well.
Absolutely.
Okay. I'll end on this question. We have 2 minutes left. I have a healthy lifestyle, decent sleep, eat well, exercise daily, but still have weight in my abdomen that I know can become dangerous. Concerned due to family history of diabetes. How can we effectively address weight gain that is hard to lose at this phase of life?
You take that one, Mary Jane.
All right, that's a hard one. This is a problem for just about everybody. And even if people don't gain weight, they tend to redistribute towards the belly, sort of a centripetal distribution there. Again, I say, please be careful about what you're eating. The other thing, of course, that I try to go through with patients is, what are you drinking? Because, and the most effective way that I can get people to stop drinking is to tell them how many calories there are. Basically, you have a glass of wine, 4 ounces of wine, that's got about 150 calories. So if you're drinking 2 glasses of wine, that's 300 calories right there. And it's about, most of the weight people talk about 3,000 calories per pound. So if you get rid of the wine, that'll take care of a lot. And also, if people are worried about breast cancer, wine is a lot bigger risk than hormone therapy. So just to put that into context. And the other thing, I'm an exercise lunatic, and I'm a convert, and converts are the worst people out there, because I never exercised when I was younger. It was awful. And now I'm a nut. So anyway, that exercise is great for you. It will help you sleep better. Do your exercise early in the day if possible, rather than doing it later in the evening or anything like that. And not only do you want to get aerobic exercise, but you want to do strength training. And strength training is good for your bones, which is very important. It's good for your heart. And by building more muscle mass, you will actually effectively utilize more calories. So I
love it. I love stopping on that note, because I think that's a big one. Thank you both. We made it. Jessica's going to take over from here. And you guys, letstalkmenopause.org if you want some more information. And I know there's a lot of incredible resources